this under the Joint Economic Committee. Because we are trying to put together a couple papers that are going to try to argue a innovation technology approach on our healthcare. So we're going to start, and I'm going to ramble for a moment, and then why don't we, Aaron, we'll start this side. You're going to introduce yourself. You're going to tell people what you do. But as you do that, I know you all have scripts in your head or on paper. Give me your best guesstimate what the next year, 2 years, 3 years looks like. Because that's, I mean, you're already there. All right, let's go ahead and sort of start formally. I'm David Schweikert. I'm chairman of the Joint Economic Committee. I'm blessed to have a number of our economists here. And what we're trying to do is see if there's an approach for the future of healthcare where I don't walk in as my position in Ways and Means and basically our oversight of things such as Medicare and basically say, hey, our only approach, we're going to make this work is, I'm cutting 5% of your budget. Reality of the math. And this is my intense frustration of the people I work with. CBO about 2 weeks ago put up updated numbers. 6.5 years, the Social Security Trust Fund is gone. And we double poverty of seniors. 6.5 years, the Medicare Trust Fund is gone. And for those who live on Part A, it's already, our structural model is an 11% cut. And if you're a Medicare Part C provider, an advantage of those, it's dramatically larger. You look at the formula. If you add those two trust funds together, the next year I would need about $600 billion, maybe 638, just to cover that shortfall. That's basically about, by that time, half the defense budget. There's a misunderstanding of the demographic pressures that we're under. And then the second thing we hear constantly, well, we don't have enough medical professionals. We can't get enough primary care doctors. We can't get demographically, stop pretending tomorrow you're going to set up a program where the next day you're going to have an army of new primary care physicians show up. There just aren't enough even folks moving through our university system to ever cover those positions when you consider our demographic. Remember, same number of 18-year-olds today as we had 20 years ago. Double the number of 65-year-olds. It's demographics. And the fact your government is right now borrowing over $80,000 a second. We have a math problem. That growth in spending, that growth in borrowing, is almost exclusively interest on the debt. Well, there's not a lot we're going to do about that. Healthcare. In my state of Arizona, over the last year, almost my only growth in jobs is all in healthcare. Except my problem is most of healthcare is paid through government. Anyone see a circle problem? So help us see, is there a path? We're changing delivery models, innovation, finding diseases very, very early. How do I disrupt the model? And then how do I deal with the reality that so much of Washington, D.C. despises threats to current business models where innovation is good for society, good for the budget, good for the patient, but actually forces healthcare delivery organizations to actually change their model. And I can prove that by a decade of war over just doing digital and telehealth. And the fact we probably would never be here if it wasn't for COVID, because I was never going to get a hearing. So let's have some fun in the discussion. I am going to ask also, if something pops up in your head or you want to ask each other a question, help us, because many of you are going to have much more background in the reality of what's going on, how your reimbursements work, and those. And if I don't know the answer, which I probably won't, maybe someone else here. Tell us the story.
Good afternoon. My name is Terrence
And you,
O'Neill.
and I will beg of all of you, whether you know it or not, this is a unique room. Your mics are actually over your heads, so be willing to project.
My name is Terrence O'Neill, and I serve as the Director of Operations at Calvary. Calvary, we're a forward-thinking biotech company where we actually developed a diagnostic that can detect cancer at stage 1. And this innovation is something that we believe is needed for the next few years, absolutely. We spend a lot of money on cancer research. We have for many, many years, and there hasn't been much innovation in that area. Our goal is to end cancer, period, worldwide. The only way to do that is to reduce the cost. We can't afford a $100,000 treatment around the world. It has to be under $100. That's where our goal, our target is at. We've developed the technology. We've merged 2 different proven technologies, semiconductor and peptide synthesis. This is actually a wafer that you could see at any Intel fab around the valley. We've actually built peptides on this wafer, over 1 million peptides, where we can actually detect cancer at stage 1. Our research is proven. We've published many scientific in many scientific journals, peer-reviewed articles. We just need the backing. We need to get our voice out, to get the research out, where people can start to see and believe that this is something that is doable.
I have so many questions for you. Joan.
Thank you, Mr. Chairman. For the record, my name is Joan Kerber-Walker. I am the president and CEO of the Arizona Bioindustry Association. I also volunteer as the chairman of the board of the Opportunity Through Entrepreneurship Foundation, which in partnership with the state of Arizona has AZ Advances, which is focused on moving health innovation forward faster. It's my privilege to work with many of the people in this room to do 2 things. 1, take care of patients. They are our #1 priority. And 2, bend the healthcare cost curve. Because as an economist and as the end of the baby boom, I am now a Medicare beneficiary. So it is important for me as an economist to be able to explain to our health innovators why we need to prioritize cost-saving therapies, treatments, and IT infrastructure now, so that we have the resources for the future, and to share with our elected leaders like yourself, what are the things that we can do to move innovation forward faster, and what are the things that are getting in our way. Thank you, Mr. Chairman.
And when we come back, I'm going to ask you to talk about some of the most disruptive innovators you believe that are a part of your state.
And I will do that.
Doctor, welcome. Now, where'd you fly in from?
I flew in from San Francisco, and thank you so much for
Well, at least it's not too bad of a flight.
This is a perfect day flight for me, in fact. Yeah. Thanks for the opportunity. It's a pleasure to meet everybody here. I am Adam Moskowitz. I am the co-founder of a company called Doctronic. We are an AI native digital health company that focuses on providing high quality care, and our focus is on primary care and urgent. Doctronic was really born out of the idea that we're trying to solve patient problems, not health system problems, and not necessarily doctor problems. And when you're a patient within the healthcare system, you really only have one problem, which is access. How do you get the right care at the right time? And the reason that is so challenging today is because we don't have enough doctors. Medicine has always had this fundamental math problem, as I mentioned before, where supply will never meet demand. We'll never have enough doctors or providers to meet the demands of patients. And I think we all know that deep down inside, because think about how many times you wanted to see a doctor and you said, that's just going to be too hard. I'm not even going to go do that right now. And so our thesis has always been, how do we improve access? And I think we're all aware that about 3 years ago, a new technology sort of started poking its head out of the ground called generative AI. And my co-founder and I looked at that and said, you know, this technology is in fact a silver bullet for this particular problem. And that for the first time in human history, if we use this properly, we as a community use this properly, we can actually provide high quality healthcare to anyone, anywhere, anytime, for free or almost free. And when you do that, you really make access universal. And so that is the goal of what we're doing.
I have almost as many questions for him. And
Thank you.
And I should disclose, Banner has been remarkable, helpful to us in building data sets and just answering sometimes crazy questions. And we really appreciate the access to your team so far this year.
We really appreciate that you're interested in asking questions. So I'm Amy Perry. I'm the CEO of Banner Health. We are a very large integrated health system. We have the acute care side, 33 hospitals across 6 states. Our primary home is Arizona. We have physician practices, outpatient imaging, urgent care, ambulatory surgery. I'm trying to think all of the requisite healthcare needs you could probably have. But what is the interesting part of Banner is that we're an insurance company. So in addition to the care, we're providing the coverage. And that to us is the sort of next generation of how we move the cost curve. Right now, and this is true across the United States, most health systems need people to be sick to get paid. So obviously that puts the incentive right there on, dealing with that sort of reactive care. So at Banner, we have an extreme advantage in when we have a premium dollar, we're able to invest in prevention, which is what we all want to do. We want to stop people from needing the most expensive services. So we right now are going through a transformation. You said what's going to be the next 3 years. Right now we're about 1/3 of our work is premium based and 2/3 of our work is fee for service. And we're trying to flip that. We're trying to get as aggressive as we can in moving to the premium based care space. And we believe that that is the right pathway. It's fraught with risk and other, competitors. But with Chairman Schweikert's help, we've had some innovative approaches to trying to change the Medicare Advantage program and doing other things that help keep regional provider sponsored health plans, in a successful category. So there's a lot ahead. I have 1,000 ideas about everything that has already been brought up. But I think just to know that Banner is trying to be part of a solution and not just rooted in don't change anything. We're trying to lean into the disruption to find a path forward that makes the most sense for everyone.
You have how many employees?
60,000-ish. And an $11 billion impact on the state of Arizona alone. Yeah, I mean, I liked what you said in the beginning about economic impact. These employees rely on Banner. I still think that we can employ under a different reimbursement model in a way that still has the same. But, the government programs from on the provider side, they don't cover the cost. So the truth is, and this, the cross subsidization in our industry is.
But that's going
Very-
to continue
Yeah.
demographic.
Right.
It continues, and there's the problem of we've already had this. Sorry, we do this all the time. I don't think the current model works. It doesn't work. It barely works today. As my demographic shift and the federal inability to, when over 1/3 of the federal dollars are borrowed.
Alignment. We need
Then it
alignment.
may be a revolution in how healthcare is delivered.
I agree with
And
that.
and so instead of, remember, much of what Congress does is we've turned healthcare into a financing model.
It is a financing model.
And that's the problem. So, Jonathan, tell us about Whoop.
Thank you, Mr. Chairman. My name is Jonathan Jeffrey. I'm the Chief of Staff at Whoop. Whoop is an American Boston-based wearable technology membership. The company was founded in 2012. Our mission today is to unlock human performance and health span. And we say human performance because our origin is in sports. Two of our first 100 users were LeBron James and Michael Phelps, local here. I think if you had asked 10 years ago, would Whoop have been in a room like this? The answer would have been no. But today, as we look at where the company's been and where we're going, we have millions of members in the United States and around the world who are using Whoop, not just to understand how many steps they walked or what their fitness regimen looks like, but to truly understand their health. And we believe that Whoop has and other wearables too, have a huge opportunity to play. Mr. Chairman, you asked, what does the future look like in a number of years? And I can't predict everything, and there are certainly people who are maybe closer to the macro of the system than I am. But I can tell you at Whoop, we do believe that there is a huge opportunity to rebuild what we call the health operating system. And with the emergence of generative AI and the ability to unlock data sets, we think that there's an opportunity to massively disrupt the system. And that doesn't mean doing away with every system that would be considered legacy, but it does mean rethinking what that looks like. And our pursuit of that at Whoop is centered around 3 elements that we believe will decide who wins having the right to effectively build this operating system. And it's data. Do you sit on top of data or have access to data that can help understand determinants of health? Do you have an AI layer that can help process that data and truly understand what is an outlier, what is a biomarker, what is a blood marker that's an outlier that could be indicative of cancer, that could be indicative of chronic disease? And then the third, and I think this is the hardest for the health system right now, is daily engagement. How do we find solutions that are actually products that's technology that people truly love and want to engage with? Because if we want healthcare to be truly preventative, if we want our patients to have true ownership over their healthcare, it cannot be reactive. It needs to be part of a system and part of a technology platform that people genuinely want to engage with. So this race, I don't think has been won. It's certainly a race that Whoop is fighting to win. But I think there are a lot of companies out there doing great work. And we are very bullish on a lot of what's coming out of DC right now in terms of rethinking some of that, whether it's the Medicare Access Program, whether it's thinking bigger in FDA about how we can give Americans access to metrics that once were considered purely medical. And so we're very optimistic, but there's a lot that needs to continue to change as this new technology comes online.
Mr. Chairman, thank you. I'm Tom Eisenmenger. I'm the president and CEO of a local company here in Scottsdale called Regenesis Medical. We're a non-invasive pain management device focused on diabetic neuropathy because the current solutions out there, frankly, are not ideal. It's pharmacological products that have suicidal ideation as a side effect. So one of the things that we're doing with our technology is trying to move the point of care to the home. I think that does reduce the cost of the system. I'll echo some things other people are doing is we're building a 2-way communication device that's going to be released later this year. So we'll know real time whether the patient is being compliant. It will be able to connect to things like CGMs, to potentially your device so that we are building those data sets so we can have early intervention. I just read an article in Esquire this past week where somebody was wearing an Oura ring and the text message that came to him caused him to go to the ER and it saved a really expensive problem down the road. And I think that's where healthcare is moving. The interconnected devices, the ability to use AI to do upstream intervention before it becomes a chronic problem. The other thing that we're doing is we're trying to increase patient involvement in their own care. I do believe that if you get the patient involved in their care, that you're going to have less downstream costs in the long run. The other thing we're doing, and I know a lot of companies don't like to hear this, but I think we need to move to a value-based risk-sharing payment model, where if my device doesn't work, I don't want to be paid for it. Pay me for what's working for the patient.
That's pretty novel. Mr. Chairman, it's great to see you again. Thank you. I'm Brad Fox. I represent a company called Health Bio. We're currently an IND-enabled company running a pivotal phase 3 trial in long COVID. And, one of our struggles is, like Tom's company, we want to impact this process of discovery to bedside. And even more so, maybe bedside at home. And so when we look at long COVID, we're promoting a combination of therapy along with a diagnostic. And with 13 to 15 million people with long COVID, how do you triage all those people? So especially in something like long COVID. So our company is really trying to leverage AI to not only discover and repurpose drugs, but also have an impact on how do you develop diagnostics that can be very inexpensive, accurate, and be used by the consumer.
Yeah. All right, let me get a little more education. Terrence. Walk me through, are you taking my blood? Are you then, what's the process?
So we're a diagnostic company first. So we're building a platform for multi-cancer early detection.
Okay,
So
we've moved that piece of legislation a couple times now.
So that is blood-based. And we actually wanted to get to a point where it can be done at the home. Where we can
Walk me through, because look, I have I love them and I do it every other year, the Grails. And I know there's some ones that are now actually moving into where they're gonna actually be looking for, to say it's simply dead DNA strips. They're actually, to actually trying to line up a series of sequences, which seems a little over the top, but how,
our technology is based on RNA.
okay,
So it's RNA errors that cancer creates. So in that replication, RNA creates a lot of missteps or encoding errors. And so that's what we're looking for in the blood sample.
And what's the breadth of the different cancers you think you can detect?
We can do any cancer. Quite honestly, every cancer has its own signature. We need to find that signature, but it's all RNA based. To date, we've been able to detect breast cancer and also different cancers in canines. We've done a huge study, a VAC study with canines, the largest clinical trial. And so we've been able to prove that we can detect at early stage 1 cancer.
What's the
What's
the speed of the test? A couple of years from what will be the speed?
a week.
Okay. So Doc, how do you take where you think AI is going? If he can do that at in-home, and eventually, how do I ever get Whoop to become a on-the-wrist medical device? Look, Apple took theirs through on, what was it, heart?
That's right, for their AFib clearances, exactly, yeah. And we do have FDA clearance, sir, so I will say that for our usage.
This is the same one?
We have a 510K based off that.
Okay.
I think, look, there's you're talking about like, how do you sort of pull together disparate parts of the healthcare system and provide it to patients?
Look, I'm a unified theory person. I need to crash the price. I want to stay healthy. How do I use that thing that supercomputer I walk around, my willingness, either to myself or, someone that's in poverty or someone that's on Medicare or someone that's in hospice, to put the thing on their wrist, or the thing they breathe into, or the thing they urinate on, or somehow where I'm producing the data that your system can say, here's your issue.
Yeah, I mean, so I think, quite honestly, the technology to do that exists today, right? There's no technological barrier to what we're doing. The products actually exist today. And if you look at what we did in the state of Utah,
Hey,
it really is.
Can you tell that story? Because that's one
Yeah.
of the reasons we chased you down.
Yeah, so,
So you should hear what they're doing in Utah, because I want to do it here in Arizona.
so, you know, I think, and going back, the technology exists today. I think Jonathan, Terrence will talk about how the technology exists. And the connectivity exists too. You know, I'm sure Amy knows that the connectivity exists because it exists within her ecosystem. The question is, how do we allow people to utilize that? And a lot of times it comes down to regulation. There's regulation out there that prevents us from doing certain things. And for good reason, for a long time, we've made it very hard to do new things within the world of healthcare because we want it to be safe. The problem is that technology has now advanced so quickly that the old ways of regulating it don't really apply anymore. And I'll use an example. The FDA regulates devices based on specific use cases. You can get approved for one disease or one treatment by the FDA. That's the pathway you go. That doesn't work in a generative AI world anymore. Generative AI is broad, it's not narrow. And so it's exceptionally hard to try and even navigate how you would go down an FDA pathway for that. What we did in Utah is we said, look, what we're doing is not a device. It is what we believe is the practice of medicine. The practice of medicine is regulated at the state level, right? The practice of medicine is regulated by local or by state medical boards. And the state says who can and cannot practice medicine. And we felt that that was an easier regulatory path to demonstrate what we were doing and to prove to, in this case, the state of Utah, that we can do a couple of things. One is improve access, as I said, that's the most important thing, but also drive down costs, right? If you can't drive down costs, then it doesn't really matter if you do something incredible because we can't keep paying for this over and over again with more money. And so we said, one of the biggest problems in healthcare today is non-compliance with medications. Non-compliance with medications actually costs the United States $100 billion plus. And that comes in the form of, I don't take my medication, and so I get sick. Or I have to go to the emergency room and renew that medication because I can't get the renewal from my primary care. All of that adds up to more than $100 billion every year.
I should warn you, my economists are back there.
Google it.
We know, we actually have a number that's dramatically higher.
It is higher than
Because
that.
we have a paper, it says 16% of US healthcare is those not engaging in drug adherence.
Yes.
Now, that's more than not getting my prescription. That's not taking my statin, my calcium inhibitor, my insulin. So, you know, those may be two different categories.
But it's still, so I quote 100 billion because that's quoted in the literature. And that's from a study, I think, in 2014. So that's 10 years or 12 years old. It's probably much higher now. But the big picture is it's huge. It's a massive amount of money that we're spending on this. And so we said, let's try and automate renewals of medications. If we can do that, we can show that one, people are staying on their medications more. And two, we're reducing the costs because patients are not going to have to go see a doctor every time you get a prescription reviewed. And they're not going to go to the emergency room when they run out of medications. And their diabetes is going to be better managed, right? Or their cholesterol is going to be better managed and their long-term health outcomes will be better. And so as part of that regulatory process, we're actually saying, let's measure those things. Let's prove to people that that actually works. And so from our perspective, that is actually the path forward to do what you're talking about, which is let's bring technology to where people need it and let's show it actually brings down costs.
What are the,
No,
Yeah.
because I was gonna ask you
Yeah,
to all
yeah.
those comments.
so what are the parameters? How many drugs, because I think that, auto refill in a certain drug class makes a lot of sense.
Yeah.
Actually, it's a lot of drugs.
So
Well-
we started with the 300 most prescribed medications in the United States. That was our sort of starting point.
And do you want to describe,
Narcotics,
you want
opioid.
to describe the Utah sandbox?
Yeah, so we went to the Utah
Because
sandbox.
we can do a sandbox here.
By the way, we can talk about this later, but we're applying the Arizona sandbox. And the Utah sandbox allows the state of Utah to mitigate certain regulations in a controlled fashion. And the one that we asked for them to mitigate was related to the practice of medicine. And we said, let's come up with a formulary that's safe.
Yeah.
We started with 300 medications. We then removed all narcotics, all scheduled drugs, all ADHD drugs, all injectables.
Good.
We then had our pharmacy team, our physicians, including myself, review everything. We removed anything that we thought was high risk. So an example, there were some epilepsy drugs that we thought, this is
Right.
probably not appropriate for this.
Right.
What was left was 191 medications.
Okay.
That formulary includes things like birth control, it includes things like mood stabilizers, it includes things like blood pressure medications, cholesterol medications. It turns out it's probably about 70% of the medications that are actually prescribed, a huge swath of that.
Oh, great. Yeah.
The other thing that I didn't realize as a physician, which is quite kind of interesting, is about 75% of all prescriptions written in the United States are repeats.
Yeah.
Meaning just by going after renewals, you're getting the vast majority of medications that are written. So you're actually getting a huge group of them. And we said, let's do this. Let's start with this 191 and let's see if that works. And we also limit the number of renewals that each patient can get. So you
Yeah,
can't,
that was my
so
question.
you can't permanently be on this, right? It's drug specific. So there are certain medications that are going to require labs every 6 months. Those medications can only be reviewed for 6 months. There are certain medications that require a doctor visit every year. And so we gated it that way. And so, it's not one size fits all, it's piece by piece, but this is one of those areas where I think every stakeholder wants a solution, right? Patients hate it. They walk into the pharmacy, they can't get their medication reviewed. Doctors don't particularly love writing renewals. I've never met a doctor who went to medical school and said, I want to write more renewals of medications. And oftentimes you can't bill for it. So it's kind of difficult. And then lastly, pharmacists and pharmacies don't like this, right? There's revenue loss when they can't actually do that. So it was a sort of perfect fit for us to start and show that this can be done safe.
Well, where are you getting the drugs from? I mean, can't people just fill their prescriptions wherever they want?
So they can fill it wherever they want, but this is when you run out of a refill, right? So your doctor writes you for let's say 2 months.
Mm-hmm.
Every time you need a new prescription, you need to go back and see them. And what we do is we say, come see us. We'll actually walk through the process and make sure your health hasn't changed, make sure you're not having any side effects, make sure that there's no new health issue that may make the drug not useful anymore. And then the AI is actually allowed to make a clinical decision to say, this is an appropriate use case for this. Let's get that medication back to you. Or this is not safe. You've got a new health issue, or maybe you've had a side effect. Let's get you to a doctor to reevaluate. So at that point, it's escalated to a new.
So when your AI is renewing the prescription, they can have it filled at any pharmacy they
Any
want?
pharmacy.
Okay, so that's not the issue. I think that duplicative, making sure that it's not filled more than once is,
Yep.
Kind of a issue. I mean, I think there's a lot of good at this. I'm like, I am.
That's solved. So
Yeah.
part of the agreement was that we use a company called SureScripts, which you probably use as well, which covers about 95% of prescriptions out there. And
Right,
so we can identify beforehand whether or not a patient has actually had this refilled somewhere else.
right.
So that prevents us from duplicating it.
So a couple questions, sorry. Obviously, one of the things that we deal with, and we have a lot of AI in Banner already, but the liability issues around AI
Yeah.
are crazy and complicated, right? So let's say someone uses your drugs and has an adverse drug, reaction. Who's liable? The doctor that originally wrote the prescription, or do you take responsibility once you renew?
We went that extra step and we said, we want to be responsible. We
Okay.
take the liability. So we actually got, I think, what was the first ever AI malpractice.
Yeah, I think that's fascinating and incredibly important in the litigious environment.
Yeah.
Did the Utah Sandbox find you any tort liability?
I think there was, and I'll have to remember back, I think there is similar protection.
Or a threshold standard?
Yeah, there are similar protections, but no, we are not as protected as doctors are. So our AI malpractice was more expensive because you can only sue a doctor for a certain amount based on regulations. There are no technical barriers to how much somebody can come in and say we're holding you liable from a purely regulatory standpoint, because those laws don't exist, right?
Right. Yeah, no, this is a interesting part of AI that we're all trying to deal with. But I think that, this is an important part of the team care. How we are deploying technology right now, it's how can we fit it in safely? I think renewals on Telmasart, probably not huge risk, and I think that I can't imagine who doesn't want it. I mean, you're right, the physicians don't want to spend that, their inbox is already overflowing. There's a lot of positive with this. It is a change from traditional medicine, there is a control factor that people have to give up a little bit, but then the big question always comes around liability. So, that's something that I think, and I do think we need significant tort reform. But I think to the extent we could work that in, I mean, I have no problem trying this in some of our clinical practices. I think it could be a benefit to everyone, and anything that helps our patients stay well, that's what we're about.
Yeah,
Now, is there ever a world here, sorry, I'm gonna leave on, that, okay, the data coming off my Oura Ring, Whoop, all the other things, ends up helping your system make the decision saying, okay, typically on this drug, I want you in every 6 months, but we see blood pressure, latitudinal data there. We'll see you in a year.
yeah, absolutely. I think, we were talking about this earlier, but, the data is extremely helpful. The key is being able to see the signal through the noise. And I think a lot of physicians out there, their knee-jerk reaction to is this genuinely, what do you want me to do with this, like, this data set that I've never seen before?
But in many ways, I don't, want your system, not the physician,
That's exactly right.
to say, because they'll never see the.
So the doctor should never look at, I agree. So that is what I think happens, as we start integrating is the system's gonna say, hey, look, I saw an abnormality.
So like, okay.
Yeah.
Policy wise, so you approach Arizona, say, I want a sandbox to do this. Do you do an amendment on your sandbox saying, oh, by the way, when, he has his blood pressure tracked or those things, and it has an FDA, within this area of efficacy, you can also use that as one of your data points.
Yeah, that's an interesting point. I think, we are gonna have to revisit how we regulate these use cases, right? Because you don't wanna be going back every single time to the sandbox and saying, hey, we have a small change to this. We're gonna now integrate this data.
But you can design the sandbox in multiple ways, the right to prescribe, but also a tort is standard shield. Arizona has some quirky tort issues in our state constitution. And trust me, I've already run 2 campaigns back in the 90s and I have scars to show. But we were able, and it did pass our state Supreme Court, of changing some of the threshold standards.
Yeah,
I would think if you produce data, just as you're trying to, produce data for payment. If I did a multi-cancer blood screening, if something got missed, but within the efficacy of here's the, the latest best technology, should you have liability for providing the best clinical data? But we gotta find a way to change the inconvenience, the number of people who, they're busy in their lives, they're just trying to get their kids to school or find groceries, and they have there's something goes horribly wrong because of that lack of efficacy.
Yeah.
So,
Well,
Mr.
and
Chairman-
we have to even the playing field. I mean, I think that I'm all about tort reform for, within some reason that has to apply across the board. It couldn't, if we're gonna do, so, I would like to be cognizant of if we get some freedom of refilling, auto refills, whatever within the sandbox, they should apply outside the sandbox. We're all trying to do the same thing, which is create more access for patient care.
Well, and I must step on you,
No, go for it.
I'm trying to find auto magic.
Yeah, we are too. I mean, we do a lot out of
Matter
it.
of fact, okay, I'm gonna wear the ring, I'll keep it charged up. I genetically have had high blood pressure since I was a child. Okay, so I've been functionally on a calcium inhibitor my twenties. You have my data?
Yeah.
He'll have my data. Can it just hit your AI? And can you just mail me the damn bill?
Oh,
So I
yeah.
don't have to go,
We
stand.
can do that too.
That-
I mean,
But
it's
that's,
not limited to people who make rings.
I
We-
agree,
we
no,
get
it
that
should, I think
data.
it should be
but,
within a
but
system.
can you can you now process the data from this ring and just auto renew?
I can
Without
re-
me, without
yeah.
me having to go see a doctor.
I can renew you without you seeing a doctor.
That is,
But how would you get that data from?
Well, it depends on
Yeah.
what data we're looking for,
Sure.
well,
right?
right now doing, if there's the widely commercially available functionally, my walking medical lab theory. And I gotta remove the word walking because it may be the breath biopsy I keep in my home medicine cabinet, or, all the other articles that I make my poor team have to look at. Where, here's the toilet that actually looks at certain things. Here's, the thing of the wrist. I've been experimenting with the blood glucose, which is remarkable what you get from that.
Yeah.
Um,
I think you're talking about proactive care where you don't have to be initiating it yourself. There's essentially like a layer, sort of technology layer that's watching you and getting biosignals from you and then able to actually act
And
without
helping
you.
me not have an event.
Yeah, and able to act without you having to initiate the care yourself.
So how do I go from those of us who are, hyper compulsive on these things and take a portion of my population that by 28% of my population that's getting its healthcare through a Medicaid system, let alone my Medicare populations, my state employees, my retirees, my VA populations, those. And say, if you wear this after your initial doctor's visit, we can renew. And have I saved some money in the system, not by cost of the prescriptions, but by the lack of a stroke or the lack of a very expensive insulin.
Yeah, I mean, I think it's all about aligning with incentives, right? Find where people actually want to get their healthcare, where their pain points are, and say, hey, we're gonna solve those for you, right? Let's get you to a point where you're gonna utilize this technology because it's solving something for your day-to-day life. I think that's the onus is on us to do that to some degree.
Mr. Chairman,
Don't.
I think there's a couple of things that we need to add to this discussion because the reality is that the majority of the population is not going to have an aura ring, is not going to have the tool.
See, I'm not sure that's true.
They won't. So here's why I think it is true. So when we look at large ERISA plans, my husband is one. He's employed by a company that has 87,000 employees. And they provide all of the technology you could possibly want. They will send you the, I want to keep the brands out of it, but they'll send you the heart monitor, they'll send you the blood pressure monitor, they'll send you the ring, they'll send you the watch, they'll pay for the whole thing. Less than 20% of their employees will take advantage.
If you haven't created the incentives, look, all right, I both love and I know it's absurd, but in the last 20 years, what was our only success in getting young people to go out and get healthy? Pokemon Go, a private gamification.
Exactly.
Design a gamification or design an incentive structure. Hey, you wear, and we have examples of, we know our poverty population, almost a disproportionate share of them have a type of smartphone. It may not be an Apple phone or something fancy, but that's their access to internet. That is the fact of the matter is, if that person has a smartphone, I already have the platform. I think we have to be a little more visionary of, is it a combination of gamification and the incentive structure that if you've been doing this, you get something.
Yeah, Mr. Chairman, I'll just add, we have a whole task force dedicated to gamification because our business model, we're a membership, it's a subscription. So we only win if people want to renew. And every day we're looking at engagement data to figure out, did the cohort that started 12 months ago, are they still engaged? Because we need them to renew for our business to be successful. So what we've done is we packaged, instead of just throwing data at people, what we do is we find ways to make it really engaging. We give you your WHOOP age, which is your biological age next to your chronological age. We have a community, so you can be in a team and see, oh, this is, my brother's recovery score versus mine. This encourages me to sleep more and practice healthier behaviors. I think you are absolutely right. Like, and these studies are shown all the time. You throw technology at people, it's like a 20% uptick. The key is finding ways, how can you make that as engaging as possible? Or pair it with incentives where you say, I'll give you another fun example. At Whoop, we pay our employees to sleep. So if our employees get an 85% or better sleep score each month, they get an extra $100. Obviously, this is very on brand. It's just, our companies, maybe naturally inclined to support something like that. But there are ways to build incentives around individual behavior and encourage individuals to take control of
We
their health.
use carrot and stick as incentives for years, right? We price health insurance higher for smokers than non-smokers.
But those are commercial market incentives. The reality of the government market now is half of our,
Yeah.
So, Amy, there was an experiment, and God forbid it was before your time. I'm on Access, our state's Medicaid system. Here's an incentive not to walk into the emergency room, but to go to the urgent care center. A debit card or something like that.
Yeah.
Have we been moving forward with any of
Oh,
those
yeah,
types of
we pay
incentives?
people to do screenings to stay on, to stay on their chronic disease programs. We, $20 a pop on a debit
Mhm.
card, I think it's moderately effective just because, we're looking at socioeconomic issues that are not experienced by the people in this room. And it's it's a much different reality. Yes, they have a smartphone, but they might not have access to healthy food, sort of that's the yin yang of,
So, but
what we're
back to
dealing
the
with.
unified theory, look, is it moral as a society to give someone an EBT card and say, go buy onion rings?
Well, it's limited. I don't know if you could buy onion rings, maybe.
Of course you
Okay.
can. I can show you the
Well,
Jack in the Box.
it's a
almost right over
vegetable.
here. I can show you the Jack in the
don't-
Box right over here that
Yeah.
has an EBT sign in the way.
Yeah.
I love the onion rings, but.
And we could, by the way, I don't know what our debit card allows, so I'm not sure that that's. But yes, there's opportunities to continue to evolve the system, but food is an access too, and nutrition is an access, fitness is an access. I have an Oura ring I don't wear because you have to charge it. When am I gonna charge it? I'm gonna charge it at night, then I don't get my sleep score. Technology is evolving. I couldn't be more excited about it. Okay, I'm in. I'm in. We're deep in AI and Banner. But there's a reality at this point. Where do we run to first? How do we make the biggest
See,
impact?
Yeah, this is a debate we have constantly is it this or is it a combination?
Yeah.
Yeah.
It has to be a combination.
Right.
And look, I have to get a multi-cancer blood screening. How often? I know some of the say you should do it every year. We've been trying to do it every other year.
Well, I think to
What's
start,
our future?
to start would be at your yearly physical. You can take a blood test for cancer screening, but it can be something that can be done more often, especially if we're able to mail, some type of swatch where somebody can just send it from home, maybe every.
Explain that even a little louder, because I know there was the discussion.
So we're talking
Right. Where-
dot test or we
Is this where I prick my finger and put the?
Right, prick your finger, you put it on a tab, and send it in, and you can actually, take that Sarah and put it on the test in the lab. So you can submit your own blood sample periodically.
Okay, so like when I've done one of the multi-cancer screening tests and they took $900 of my money.
Yeah.
And I paid for it, but I just personally. And I had to go to a lab for them to put I think it was a 20 gauge needle, so it wasn't too much. That's not my future.
Right, absolutely. One, it's too much, it's too much blood, absolutely. I mean, that's a deterrent, right? But if you have something inexpensive, you can have a small drop of blood to actually run a test. That's probably a little bit more feasible.
See, I
Mr.
take it
Chairman- Yeah, go
a
ahead.
different level. I would say, let's connect all these devices. So you're gathering a database, connect the CPAPs to all this, right? You know what the risk factors are for lung cancer, for example. Were you a former smoker? Are you a smoker now? Do you have COPD? CPAP's gonna tell me if I'm developing hypoxia. Now you have precision outreach. And you reach out directly to that patient and say, you need to go get that test done now.
Yeah, I agree.
Now you intervene early and you can save that person's
So
life and you don't run into those
back to our-
end of life costs.
So this is to our hub concept
Yes.
of I need a universal hub for all the different data sources. And look, anyone that says, well, what about privacy? They already have their financial world behind the encryption chip. It's, I mean, the fact of the matter is, look, I can show you the paper. My medical records on that iPhone are safer than the doctor's office because it's behind an encryption chip. Look, you have the freaky smart people around you. Am I wrong?
I think it's important to acknowledge privacy is important for most people out there. And I think one of the reasons why we've been successful is we've put that front and center, and said, privacy is important and we'll try and make this as secure as possible. And the other thing that we've done that is to say, your data is yours, right? And I think that's another, there's some tension here, right? I think there's some people here who are gonna say, no, we want to keep the data. That's really powerful for us. And I feel, and this is just something that our company has sort of been developed around, is patients should own their own data. And that's what we feel. And while it's not necessarily the best business model to do that, I think it allows people to feel safer and more secure when they store data somewhere and they know that it's theirs. They can delete it, they can transfer it, they can use it however they want. So I think there's two things essentially to get back to your point, which is one is security. And I think the data is more secure on your phone than it is other places. And two, autonomy of your own data, meaning you own it, you can control it.
Does that cause you trouble?
Well, there was a couple of things that came up. I do think Tom is making a really good point about focusing our resources on information that has the greatest amount of impact. And when I hear, and I think I'm all about early screening, but the challenge is, what happens when you find out you have, an early screening for a cancer that doesn't have a treatment? It's sort of like genetic testing. We can test for 1,500 markers, we could treat 50. So, it's getting data without being able to act on it. So I'm a very practical person when it comes to what can I do with the data I have? Is it actionable? That's the data we need to focus on today so we can take action. And we find a lot of things. It's like we behavioral health screen every single human that walks in our door. Do we have behavioral health resources to match that? So, right. So it's like, how do we start matching, the areas where we can actually have an impact?
Okay, we played with some calculations a couple of years ago, saying, okay, if 5% is 50% of my spend, and we were focused on Medicare and Medicaid populations. How do I take my 5% multi-chronic populations? And we actually did this big math experiment in regards to blue ties.
Okay.
And we have a running debate because the paper that was our base is several years old, but it was categories of obesity being almost 47% of US healthcare spend. So in that case, build a model that says what happens over a couple of years if you help part of your population get its, particularly those who are in morbid obesity. Is that moral? I think it is. But back to if I have 5, that's 50. Right there is, where you start. Is your multi-chronic populations.
So yes, and if all we did was make having an advanced directive a prerequisite to Medicare.
Mhm.
And by the way, an advanced directive can say you want 62 MRIs on your last day of life. It's not telling you you have to die.
Look, I'm the sponsor of
If
Arizona's
you do that,
directed bill, so I was
we-
in that path.
We completely change because it's the 5% that are spending the 20%.
It-
It's those kinds of things to create that focus on where the dollars are being spent and where they could be spent better.
Okay, we need the actuary in my charts. Because.
They're over there, they're working on it.
On a personal level, I will tell you, I can show you, the end of life math isn't what we have pop culture telling.
We should look at it because
Because
it's pretty compelling, even if we just look at our own data.
The person that has diabetes that's gonna live another 30 years, but during that time is gonna lose a foot and end up in the emergency 6 times a year. That's.
Part of the opportunity we have. I agree.
Yeah.
I'm not saying one is more important than the
Well,
other.
step in here and bail me out.
I'm saying they're
See what you're
both,
doing just fine
but these
yourself.
are the areas to focus, David. I think you're absolutely right. It's like,
But in
where do we?
previous
go?
life, I did a certain amount of healthcare finance work and.
It shows.
So as one of the economists, if we look at where our spend is greatest, our spend is greatest in our over 65 population. And there are 5 or 6 diseases, most of them chronic, that are the predominance of that spend. So looking at specific innovations that can bend that curve quickly is where we'll get the biggest bang for the buck, going back to your 1 to 2 year parameter. Okay. So when we look at something like Calvary, and Terrence did talk about, cost. So the cost of the Calvary test, once we commercialize it, is $100 to $150 a patient compared to the test you're getting,
Oh, yeah.
which is $1,000.
And apparently there's a new paper out just last week that statistically there's too much noise in it.
The challenge that, with that particular study that did not meet its endpoint is that, number one, it wasn't a long enough study. So a lot of the things they were looking at, but the other thing that was not looked at is that particular test is not sensitive enough to go down to stage 1, stage 2. And so with stage 1, stage 2, that is your early detection. Stage 3 and stage 4 is your disease treatment. That's when it gets
So,
expensive.
okay, let's take a leap sideways because we've been geeking out over here. Okay, so you have every resource you could possibly have. How soon can you commercialize them?
Depends on the money.
So you
Here's-
have every resource you possibly could. How long does it take to commercialize?
We had
To get through your certifications, your FDA approvals, those things, just a normal clock. We have venture capitalists throwing money at you.
I mean, we're beholden to the existing,
That's the point.
Okay, so
the
let me
timeline
help
right
that
now
one.
would be how many years?
it could be 10 years.
So let's look at it a different way. We as a nation know how to accelerate things. Okay, we saw it with COVID tests. And what it takes is a centralized focus. And quite frankly, if we were to do something like Operation Warp Speed and target cancer, I'd love to target Alzheimer's, but as Eric Ryman has taught me, those treatments are a little bit further down the line.
But not really. I was thinking while we were talking, we have a finger prick test that you could do, like that we're under development. We are very, very close. That will be able to detect whether or not you have Alzheimer's disease.
Okay.
That could be a global solution to early identification. We do have some treatments that are showing significant slowing of the of plaque development.
Is it the amyloid plaque?
That's right, and that's right now, today happening. So Cause I was thinking when we were talking about like the cost curve, Alzheimer's, we're on it. We've spent hundreds of millions of dollars trying to get here. Parkinson's disease, we're doing stem cell transplants right now, hundreds of millions of dollars in disease prevention. Those are the things, societal expense, that are just beyond, you know.
In the summer, I went to New Hampshire and to the lab where they were growing islet cells, undifferentiated islet cells. So they don't, they believe they won't even require anti-rejection. A bit of trivia for our Medicare population, 31% of our spend is associated with diabetes.
Yeah, it's just stunning.
And
And
that's
so-
our Medicare population.
Yeah, it's stunning.
So when we look at diabetes, right, you and I spent a lot of time talking about the medications that are now commercially available to help people with obesity, right? And this committee wrote the paper, and then I took it and put it in layman's language and put it out across.
I thought we did write it in layman's language.
Yeah, I had to take the economics out of it and make it even simpler.
Oh,
But the point is that when we look at the major disease states, and if we use cancer, Alzheimer's disease, diabetes, if we make a significant chunk heart disease, we have the tools for heart disease, right? Other than modifying behavior, which is the hardest thing to do. But when we look at the other chronic diseases, those three are our predominant spend. And so, moving from, how do we interconnect everything to how do we take some of the things that, as Amy says, we have invested billions of dollars in and get them to the finish line. mRNA was, it was the joke of the investment community, and I can say that as an investor, right? Before COVID, if you had an mRNA company, you couldn't get anybody to buy you a cup of coffee at JP Morgan, right? It was that technology that was so far down the road that nobody would ever use it until we needed it. And so were we able to commercialize it quickly? We made it a competition. We put the money behind it. We had a massive population for clinical trials, which in cancer detection, we actually did. Now, the trial with the National Health Service in the UK had 142,000 people. The trials that we had for the COVID vaccines had 2 to 3 times that in it. And I know I was in those trials. And so if we truly are serious about it, and I've been reading up because I was in DC on the 25th when Senator Ernst released the new model for the SBIR program. And in it, there's a $30 million direct to phase 2 for these breakthrough big things, big challenges. Well, their bigger challenge, and yes, the fact that you can do an early stage multi-cancer diagnostic for a tenth of what the commercial opportunity is right now is amazing. But that's not what I want. And your boss has heard me say this, actually the whole state has heard me say this. I want a world where my grandchildren or my great-grandchildren will learn about cancer in history class. There used to be something like cancer, like there used to be something like polio. And so Calgary has the technology, actually the test was created so they could test the vaccine that could prevent cancer from starting in the first place. Now, you want to talk about economics? They were spending what, $350 billion a year on cancer in the United States. So if we were able to vaccinate the population so cancer did not form, that is how you bend the cost curve.
and look, we now.
And that's a
have enough- we
$30
now
million
have a-
trial.
We have a statistically significant melanoma vaccine.
Mhm.
So world's heading there. Doc, tell me about how does the payment model? How do we get you compensated?
So right now, our payment structure is, the the patient pays, or we connect it with the traditional telehealth business.
Okay,
There is no reimbursement right now for AI enabled care, right? That's not part of the reimbursement model. And so, there are ways in which we can incentivize using this technology. And it would not be that expensive relative to how much it costs to see a doctor. And if there was a reimbursement for an AI standalone product, then I think you would see adoption happen much more.
can you ever get me a telehealth model where the doctor I'm talking to is an avatar?
Yes.
And, so that way, in the middle of the night, when I have a moment or when I feel yucky, I can talk to my fully digitized, super freaky smart, because it's the best AI possible, telehealth doctor,
Yeah, no, I think that technology exists today
and could prescribe.
and it can prescribe. I mean, in the end, you needed to have some sort of action, right? It needs to actually do something for you that's gonna help with your health. So it can be a prescription, it can be writing for
So I could be talking to my avatar telehealth doctor, and it could be also looking at my last 2 weeks of my data off my Whoop, my Oura Ring, my Apple Watch, whatever digital I also plug up into.
Yeah. I think you're describing what your first question was at the beginning of this, which is.
Making a circle, dude. You're very good.
Very good.
You know, and there's a reason for that.
Yeah, I think
It-
three
it's
to
I'm
5
trying
years
to
from
connect.
now will be, and to go back to a point you made, I think my children are gonna look at us and say, you let a human being be your doctor at the point of first contact. I think 25 to 30 years from now, a significant portion of our healthcare is to be done through AI.
So I have 60,000 employees in my business. And besides my real estate, my employees are my single biggest cost. You have to manage this organization with a revolution coming.
Mhm. Yep.
Maybe they should pay you.
Well, we have to deploy technology. We have a ChatGPT that's in a safe environment. We are very sensitive to HIPAA. We have something called BannerWise. We deployed it with Anthropic Claude language. It's exceptional at being able to leverage AI as part of our care to get there faster. I do think, I'd love to understand your model more and how it could be part of our care team. I think there's a cost avoidance potential with your company and how that plays into, sort of an organization like Banner that wins with cost avoidance, right? So, I would be really curious to understand how it could be embedded in a process that's, already evolving.
Right. That's the model today, right? Because obviously we, from a regulatory standpoint, can't actually practice medicine.
Yeah.
Model today is, how do you provide access that's universal and then embed that in a sort of AI native care delivery model so that a patient can get the right care at the right time? And so what we've found is that there's about a 15-to-1 ratio of AI only care versus AI plus human care, right?
Yeah.
So what you're doing is a lot of people are practicing self-care. They're not
Yeah.
going to the doctor when
For
they don't
sure.
need to.
Yeah.
And then the people that do need to go to the doctor are finding them faster, right?
Mm-hmm.
And so in that sense, going back to what you said is, you're avoiding certain care that is not necessary at that point.
Not high value care.
Yeah,
Yeah.
it's care that can be done by the person themselves.
Yeah.
Right? And
Yeah.
that's gonna save money for the health
Big
system.
Yeah.
And for, as a payvider, you're gonna like that because. it's
Right,
gonna
right, of course, we want.
And then the visit itself is half as long.
Yeah.
So all of a
Yeah.
sudden, your providers are twice as efficient.
Yeah, I've been talking about your model to our doctors, trying to get them warmed up to the idea of, having an AI as part of the team.
How do they feel about this technology?
I think, it is a little bit generational.
Yeah.
So, I think that, this will be really easy for some people, for our, residents and fellows. We're training 1,300 physicians
That's
a
amazing.
year, okay? So we have a lot of, Zs that are in there and they're digital natives and they're like, of course, we're gonna, like open evidence, of course, we're gonna leverage technology. So I think, but we have multi-generational caregivers, we have multi-generational consumers.
Mhm.
And so for us to meet everyone where they are it's just not a one size fits all. So I see parts of this kind of matching up with different parts of, we treat almost 4 million unique lives a year. These are 4 million people want different things. So which ones of them will benefit from these technology advancements? We've got to do that faster and better because we have to get more efficient, like you said. I mean, we got a revolution coming. We can't do it fast enough.
So speaking of efficiency, so there's a company in your district, Mr. Chairman, called Abby Now Medical. And I know you
I
have
know.
gone to see them.
I know them. No, go on. It's,
So in this case, so Adam, are you familiar with this organization, company?
No, I don't think so.
you should at least look at some of the papers, but they've also had to change their business models a couple times.
So, and the reason they had to change their business model because they had to, as Amy was saying, find who needed it. So we talked around the issue of one of the reasons we need all of this technology is we're not going to have enough doctors. And one of the reasons that doctors are dropping out is they're burnt out and they're not practicing medicine anymore, they're data entry.
I don't agree with that statement,
Okay.
and we can get back to it,
Okay.
but go ahead.
But, and I'm talking more the primary care in the field as opposed to, the specialist in the hospital. But the challenge that we're seeing is that, the process of not just triaging the patient, but getting through the medical visit and then getting the paperwork done on the back end so that they get paid for what they did and coding it properly and all of that. That's what Admin now is doing.
But and they've been around for at least a decade, and they were trying to use early AI to automate the entire steps. And even at one point, they had a couple experimental clinics and Safeways that it was you walk in, you put the thing in your mouth yourself, you put the ear, and at the end, the doctor popped up to meet state regulation. In today's world with your generative, that could have been Marcus Welby as an avatar. None of you know what Marcus Welby is.
I do,
You're too
unfortunately.
young.
No, you just,
Okay.
You just said you're a
sorry.
boomer.
For
I
you,
got it.
for you, Jonathan, Doogie House. Okay.
there we go.
But, and I'm sorry, we have some numbers that it's more than worrying about doctor populations. It's, in the current model, how many people can you hire to sit in the back room and be a biller?
Yeah.
How many of you have, in the old, the classic traditional doctor's office, can get someone to be your receptionist at what you can pay them? So we're now seeing companies like this, the reception is a big screen that actually has facial recognition, talks to you.
Yeah.
And you talk through your chart. And so they're not handing you a clipboard. You just say, okay, I want this, I want this, I want that. And the doctor's recorded as, and then you match the doctor's notes with the insurance contract. And we have something called clean claims. Saying, look, they match, pay. And there's not a room full of billers in the back. Would you believe there's lobbying against things like that? Because there's billing companies that don't like the automation of it. Look, my experience, I've been in Congress 16 years now. Healthcare is about the money. And it's cynical, but some see the line of lobbyists outside of them who often are really angry at me. And think of the things you've gone through just trying to say, if your approach actually is a disruption in long COVID, how many of those who are selling anti-inflammatory, protocols, you just put out of business?
Recover program was funded with $1.3 billion since 2023. They've spent $500 million of it, and it has not produced anything but a bunch of trials that failed on placebo. So it is, it's a challenge, but something that Amy said, deploying technology.
I'd like to partner that up with enabling physicians, because this is something that we're seeing. So we also work in the stem cell area. And it's interesting how you worked with state regulation with physicians. And we're seeing that as really an enabling thing because, last year, Florida passed a new stem cell law that enables for 3 indications the use of stem cells there. And what they're doing is they're circumventing federal law because federal regulation cannot tell physicians how to practice. And what we're seeing is that physicians are so eager to learn, okay, I'd like to use these stem cells off label. They're only cleared for hematopoietic indications, leukemia and lymphoma, but they know that they work. And so we're enabling physicians through state law to be able to take care of patients in really groundbreaking ways with things like from stem cells and the things that Tom has here. And I'm really intrigued on how do we deploy technology by linking that up using AI? Because a lot of these clinics come to us and they say, well, I don't know how to practice in this area and I don't want to get in trouble. And so, our company comes along with some AI that helps them identify how to market correctly, how to make sure that you're not circumventing federal law. And we're seeing this incredible boom in places like Florida and Utah. So I don't know how we tap into that because I think that's foundational for deploying technology in ways that physicians really want to be involved.
Oh, ask Adam, he just did it.
Yeah, that's why I'm pointing that, yeah, it's definitely doable on a state level. And I think that if we're successful at a state level, we can impact federal level.
Adam, can I ask?
Arizona's sandbox. So Arizona had the first sandbox. It was the fintech sandbox.
And tech, yes, my distributive ledger.
That's right.
And who helped them write that?
But it was the first sandbox in the country. And actually Utah copied Arizona's fintech sandbox. My kid lives in Utah, not far from Silicon Slopes, so we have this conversation. UStar also was copied on Arizona's process too. But in our conversation of how do we bend the cost curve, we're talking about a lot of things that are gonna take a while. There are some things that we can do right away. So for instance, the cost of treating diabetic neuropathy is a fraction of the healthcare costs post-amputation. So Tom, how many years has the VA had access to your technology?
20 years.
And is it covered by Medicare yet?
Not yet.
Why not?
That pathway is a long and arduous journey.
Seriously, why do you think?
Well, I mean, part of it is investors know how long it takes to bring a product to market through Medicare. And so they don't want to invest in the healthcare space. There's a lot of dry powder out there with investors in medical device. So it's part of it is the dollars. The dollars aren't there. We're doing everything through self-funding. All our innovation projects are self-funded.
We're in the same
So it
boat.
takes a while. It takes a while.
Would any,
Investors are the biggest challenge.
would any of the new models that are coming to light from CMMI be helpful at all or useful?
I'm not aware enough of those yet. to be able to
CMMI
answer.
And has been.
massively grown. And when we look at CMMI and those models and how many of them have actually worked,
Mhm.
it was supposed to save us money, it's costing us. And so, I mean, if we simply at the federal level said that if we reimburse it at the VA, we reimburse it in Medicare. There is a long list of health innovations that are benefiting our veterans right now that are not benefiting our seniors.
There are a few things also at the VA that are problematic on how they do their billing and their invoices.
Oh, I'm not saying the VA is
and why
perfect
I
by
can get
any man.
This piece of equipment at this center, but I can't get it at this one, so we do have some issues. All right. So what do? You know, you're a member of Congress. Is it a universal bill? Is it inch by inch? I mean, what's the solution? You know, for you, I've had this conversation before. What do we do?
And I think it's a breakthrough technology designation that's gonna expedite the process. The other piece I mentioned earlier is the willingness of industry to say, we'll go with a risk sharing model. And industry is not willing to do that. But if you told industry you can get to market more quickly, if you can show, number one, you're safe, and there's not so much emphasis on the perfect clinical trial that shows you are this effective, that says you can prescribe this device, and if it doesn't work, you don't get paid. I
So
think
not-
there's something to that.
Not to bring up back the CMMI again, but they've just announced a model that's just that. And I think you're right, John, there, if you look at the record, I think, you know, it may speak for itself to some degree, but I think the team there seems very innovative, and this new access model does exactly what you're talking about, Tom. It says, Dr. Oz got up on stage in December and said, I don't care, we're gonna launch this new access model where we will pay for digital health technology to come in. And if you can show outcomes at the end of the 12-month period, we don't care what engagement is, but you can get rewarded for that.
So I'll share another thought is now, as the guy running the company, I'm gonna spend time and resources to look at my data and say, which patients does this not work on? You mentioned earlier you're on a calcium channel blocker. Let's suppose I find out my device doesn't work on anybody on a calcium channel blocker. Now I'm not wasting money. Because number one, I know I'm not gonna get paid by placing it on that patient because it's not gonna work. There's a lot of things big data can tell us. And I've told my company, I really want to know, I'm more concerned about the patients this device does not work on. Why? That's wasted effort. That's wasted effort, and it's wasted money.
And that's where AI can have a huge impact, because a lot of the drugs, about 30% of the population, it's truly efficacious. The other 70% is taking it, and we're paying for it, and it's not working.
The promise of personalized medicine.
That's right.
Yeah, which we have a couple companies here in town that are trying to do genetic profiles and tell you not to take this or don't take these two together. It's still early stages though. So I came to you because now you're not going to be on MedPAC.
I might be.
We should talk. No, listen, I actually like MedPAC.
Okay, go ahead.
There's there's some really good people there.
Okay.
Issues on CMS respecting the workplace.
Think that that's cyclical a bit, but yes.
The whole story went in. Okay, so you're in charge of the healthcare system. It has to be done through innovation that changes prices and helps people be healthy. What do you do?
I start with where I think we can make an impact, right? I feel that we need a different approach, and which is what I've been, trying to get to, which is, having more premium dollars, being able to invest in communities, partnering with our communities to help people stay well. That requires just a completely different approach. And my challenge for the most part in terms of our expenses isn't our people that wear the Aura ring, it's the people that, haven't heard of the Aura ring. So it's like, for me, I want to get into the community that cost avoidance, especially with the changes, there's a lot less people, that are going to access healthcare in a traditional way. How do we outreach? How do we get to them? I think the schools are a part of
But
this.
my federal clinics,
Yep.
can they
Yeah.
To help me now that I have a, whether it be technology, $149 a month blue tag tablet. I mean, is there another way I can take both what we've had from, pharmaceutical breakthroughs, genetic, synthetic biology breakthroughs, technology breakthroughs to model the ability to have a, is the battle I constantly get walked into between Cerner and Epic and others that want to say, we have a technology to hold all your charts and all your scans in one place.
Right.
Is there, well, it's more than great, but which one do I, try to say, look, everything, with AI now, there really is no such thing as an exclusive software. It can
Yeah,
be
people should own their-
translated into,
Yeah.
I agree with that.
I actually think you nailed the point right there, which is what we should really focus on. First of all, there's a lot of things we can change, right? You have a hard job trying to figure out which one we should go after first. But I personally believe that we have had a problem with what I call a floor ceiling problem in American healthcare. In American healthcare, we go after the ceiling. We try and raise the ceiling of healthcare. Think about if somebody wants healthcare and they're the richest person in the world, they come to America because we have the highest ceiling possible. We have bone marrow transplants, we have genetic therapy, we have MRIs that can detect the smallest cancers. We are very bad at the floor, which is how do you get everybody high quality basic healthcare?
Right.
And if you can incentivize the system to provide high floor, I think you'll have a much broader impact. And I don't think it's even close. I think you're talking orders of magnitude more impact than if you try and incentivize and try to raise the ceiling. And it comes down to very basic things like how do you get the community involved? How do you get people seeing a primary care doctor? How do you get people learning about their nutrition? How do you get people engaged in their healthcare? And it's an incentive alignment thing.
Yeah, it is. I just joined a board called Health Board, and they are in that school, in the high schools, trying to teach about health outcomes, in that core, like in an early stage, trying to connect health outcomes with a trajectory that includes, a transition to a career. Those kinds of partnerships are going to have such a significant long-term impact on health costs. It's not glam. It's not
sexy at all.
It's so not sexy.
It's not sexy, but it works.
It matters. And all of this stuff in trying to create, it's like not exciting, but healthy communities, engaging people who will allow themselves to be engaged. There's so many pockets of opportunities for cost curve changing. And I agree that there's a tech solution in every single one of these markets. But I don't believe that it's the same tech solution. I feel like we have to be very specific depending on the demographic, the ability, the access, the dollars available. When I think about the drugs that are available today, they're crazy amazing. They're also ridiculously expensive. I mean, we can essentially deal with sickle cell now. I mean, imagine that. One of the most horrific, diseases. But the cost, it's enormous. So, right, thank you. So we have wonderful things we do. We're curing cancer at Banner every day with CAR T and some form of cell changes. Those are really expensive. They're cures.
Yeah.
They're one time. So imagine, are you insuring that patient during the time that they're getting that $2 million cure, but you're not insuring them next year? How does the actuarial, where are my economists? How does that work?
I've been trying to fix that on Medicare.
You've been talking about bonds and, yeah.
And national pools, and I know, and I mean, there's not a lot of easy answers. I'm trying to find the things that will have the biggest impact for the most amount of people. That's why I'm very focused on Medicare Advantage. I think there's a few then you've been a fantastic supporter and leader in this space. A couple changes.
I have almost no one marching with me in that parade.
But I think people are waiting to see what happens. You know, there's a lot of skittishness, but, and I do think CMMI has tried to, you know, create a discussion for some changes around Medicare Advantage. We have, you know, presented proposals. I've seen some of that reflected in the changes that have come out. You know, I'm just, whoever wants to be part of the solution, that's who I want to talk to, you know, and you've been trying to find that middle ground. What can win? What is gonna help move this forward inch by inch? I mean, I'd love to move it forward by miles, but we've got to take what we can get.
Look, we're up against 5 o'clock. And I promise to be respectful of everyone's time. I think the world of you and your organization, we can't survive as it's inch by inch.
Yeah,
We're hemorrhaging.
yeah,
The budgetary hemorrhaging that's going on is unlike anything it's ever been experienced. And the curve gets worse and worse and worse. And, you know, it's a combination of demographics and other things. I'm gonna ask each of you if you have anything that's particularly useful on paper, submitted to us, because we'll make it part of, you know, the discussion draft. Technically, it's not the record of this discussion, but we'll use it. If I can be of any help in the sandbox concept, you know, that was something, a legislator named Jeff Winiger and I sort of, you know, came out of nowhere, feels like a decade ago, in regards to trying to promote distributed ledgers as a way to manage information and protect privacy.
Yeah.
It wasn't for a cryptocurrency, it was actually, you know, guaranteed IDs, safe medical records, you know, data that could be mined, but was
Anonymized.
yeah, it was screwed up. And we did it.
Yeah, it comes through, by the way, because when we have the sandbox, very focused on consumer protections, very focused on data, the questionnaire is very focused.
Yeah, and that's actually sort of a fun idea. I have an interest on, do I need to also build a torque box and some other things in there? So there's not a fear that, you know, so many of my wearable device companies have basically, remember, you know, we've met with some of your leadership, some of the others, love them, but you can almost see it's not worth taking on, you know, the liability.
If there's a massive litigation around.
Yeah, and litigation treadmill where it's just extortion, basically, you know, takes down the company in a competitive environment, because you have some real competitors nipping at you. You know, I love the multi-cancer screening. Look, I turned 64 in a couple weeks, a week, and I have a 3-year-old son my wife and I have adopted. I'd like to be around just to see him finish his postdoctorate. So we have high ambitions. Yeah, and so, but then again, there's no one in this room that probably doesn't have an advanced degree. And we've got to be careful that arrogance doesn't take us away from, you know, the 90% of our brothers out there and sisters who are just trying to figure out how to survive.
That's right.
And that is the world. That's why I have such a fixation that I still think there's a revolution we can do in access. You know, and so it's that that capitated primary care gatekeeper model. Now you and I get to discuss who's the gatekeeper. Is it the individual, you know, the doc down the street, or is it a combination of that and something they're going to wear on their wrist?
I'm open to whatever works.
Yeah. And all right. Thank you. I appreciate you all giving me your time. I know this sometimes feels absurd having to deal with the idiot politicians, but we're trying, particularly in my world, trying to be able to tell stories with the people I work with, that there's a path, because we are about to have a binary choice coming.
Mhm.
Cut or innovate. You don't get to live in the middle of it. Right now, most things that are moving, it's just so much easier to cut. We're gonna cap you, we're gonna do this. It's just easier. Because when you innovate, you also have to fight through a battlefield
Yes.
of people's business models. And a lot of the business models out there are more comfortable with the cap or cuts than they are with the disruptive technology that could put them out of business. So thank you for hanging out with us.
Love it.
Thank you, Mr. Chairman.